I am Kimberly Bonatti alongside Ethan Euchre.
Glad to be here.
And world-renowned orthopedic surgeon Dr. Alfred Bonatti.
Hi.
Hi.
Hey,
See, I jumped ahead. And our senior fellow, Jeff Wagstaff.
Present.
This is something that's close to heart for me because I feel like my grandmother had dementia right before she passed away. And, you know, Alzheimer's disease and dementia affects millions of Americans. And the quest to find a preventative solution is growing increasingly more important. Joining us right now to discuss is Dr. Michael Fossel, neurobiologist and author of The Telomerase Revolution. Thank you for being with us again, Dr. Fossel.
You're welcome. Pleasure to be here.
There was a paper that came out. I'm not sure if you actually wrote the paper or you just were asked to speak about this paper, but it piqued my interest, so I reached out to you to see if you could come on. After looking at the paper, I don't know what any of it means because it's just some super heavy science. So break it down for the simpletons like myself, what this means for Alzheimer's research.
This came out of a talk that the Alzheimer's Association asked me to give about a year ago. And the question that always comes up is, why does everything work in mice, nothing works in humans? And I suggested it's because we don't have an overall model of what's going on. We have targets like beta amyloid, and we have techniques like monoclonal antibodies, but we don't have any way of understanding what's really going on in all Alzheimer's. I'm giving you an analogy of this. You end up with an Ebola infection. One of the things that a lot of patients have is bleeding, but if I just treat the bleeding, I'm not treating the illness. I'm not treating the disease itself, the infection. By parallel, that's kind of what's going on in Alzheimer's. We tend to treat these sort of downstream outcomes, clinical symptoms and signs and markers, but we don't ask ourselves what's going on upstream. That's what the paper addressed.
How are we able to get kind of a preventative solution?
Yeah, where do you think the research is going to go from this paper? And why is everyone so excited about this?
There are two reasons. One is something that we all share, or almost all of us, which is we have a feeling there's something else going on with Alzheimer's and we need a better model to understand it. That's a pretty universal feeling globally. But the second question is the model that we're presenting the right model, which is a different question. It's one that we're going to take to FDA trials and see.
And how long does it take to get to human trials?
Phase 1 trial within 24 months at a cost of only $10 million, which is a lot faster and a lot less money than most big pharma spend on this. But again, the question is, do we have the right target? To quote Indiana Jones, you're digging in the wrong place, you're not going to get it. You have to be careful where you dig. You have to find the right target, otherwise you're just wasting time, money, and people's hopes.
I think with the target is exactly what you said. I think the target is multifacet. I think that different things that they create the problem. One of the things, for example, that happened to me is I have a patient who had Alzheimer's. The family brought the patient because he had a tremendous amount of pain in one arm. And after we look at the MRI and check the thing, we knew that the patient had a stenosis on the cervical spine. And we went and we did a decompression of at least 4 levels on this patient. I saw the patient almost 6 months after, and the family was absolutely shocked, saying, remember everything, is moving normal, talks normal, is totally active in society again. And I go, well, needs to be vascular. It's the only thing that it can be is that you have a compression, and the compression affect the vertebral arteries, and then the vertebral arteries, once you decompress the whole thing, the nerves start to work normal, the arteries become decompressed or become with more power by the action of the nerves, and then start to pump again in the brain, good amount of blood, and it seems to be that this patient become an example of a situation that was not Alzheimer's, was a secondary problem. So I understand what you're saying, but I think it's multifaceted. This thing needs to be analyzed different.
No, I think you hit it right on the head in a way. No matter what I look at for some of the risk factors, vascular among them, you find that they don't always explain things. Example, we all know that the single greatest risk factor for Alzheimer's is age itself. And yet, I've seen 100-year-olds with no evidence of Alzheimer's, and I've seen 45-year-old patients who have Alzheimer's. That's not to say aging doesn't play a role, but it's not the cause. We find the same thing when you look at the literature with regard to microbial disease. Now, whether you're looking at viral disease, chlamydial disease, bacterial disease, even prions, you'll find that there are some interesting suggestions that these can play a role. And yet, we see patients who have had a central nervous system infections and no evidence of Alzheimer's, and vice versa. Same with head trauma. You look at National Football League or Hockey League patients who've had evidence of trauma, much higher risk of Alzheimer's disease. And yet, you see patients with head trauma without Alzheimer's, and you see Alzheimer's patients without head trauma. The same is true of vascular issues. We know that there's an overlap in vascular factors in Alzheimer's, and yet, you still find patients who have stenosis without Alzheimer's and have Alzheimer's without stenosis. Not to say there isn't a role. There is. But it's not as simple as cause and effect. So yes, it's multifactorial. But the same is true downstream. You'll find patients who have clear cognitive decline without beta amyloid plaques. You'll find others with beta amyloid plaques without the Alzheimer's. You'll find patients the same thing with regard to tau tangles. And yet these clearly are generally present in most of the patients with, for example, classic Alzheimer's disease. The same with regard to Parkinson's and alpha-synuclein aggregates. The question, though, that we need to ask ourselves is, where's the most effective point of intervention? We have tried upstream. For example, I can lower your risk of Alzheimer's by making sure I control your sugars and your blood pressure a little bit. I can do the same thing by avoiding head trauma, by treating microbial infections, and so forth, by dealing, as you pointed out, with vascular issues. And yet, it's not quite enough. Downstream, likewise. If we go after beta amyloid, tau tangles, mitochondrial dysfunction, a whole host of things, we find that they're tantalizing hints that we're getting there, but none of them are effective. So the question that I ask in that article also, where is the single most effective point of intervention? It clearly is not just the upstream factors. It's not just the downstream factors. The question is there a better place to intervene? And yes, it looks like there is.
And it obviously seems like such a multifaceted illness, affliction, that it's hard to pinpoint what the exact cause is in order to go after that. But I also noticed, reading up on the paper and what you do, you talk about Telocite. Explain what that is and how that has shown effective intervention.
We're actually talking about telomerase, actually. Telocite is a biotech firm. But telomerase was first shown 22 years ago this year to be effective in resetting gene expression in human cells in the lab. It was first done with human tissues 20 years ago this year. For example, 19 years ago, it was shown that if you take patients' arterial tissue from patients undergoing a coronary bypass graft, a CABG, you can actually regrow what appears to be young, functional arterial tissue. But we're more than just cells and tissues. We're whole organisms. So the question is, can we do this to organisms? Well, the first attempt to use this successfully was a study out of Harvard by Rhonda Pino's group in 2011, followed a year later by a technique that we could use now in our human patients by Maria Blasco, who is the director of CNIO in Madrid. And what you find is that if you reset gene expression, for example, in brain cells, you can get improvement of cognitive behavior. So the question is, does that translate to humans? Well, some things clearly don't. We know when we try doing these things with altering mice, for example, to have human amyloid genes, it doesn't work when we take it to humans. On the other hand, we share about 75% of the genes with a mouse. And if we're concentrating on the 25% we don't share, we're not going to get anywhere. But if you're dealing with common mechanisms, common underlying fundamental mechanisms of cell behavior, then you'll get somewhere. And that's exactly what the Blasco study showed. So we're going to take that to human trials in the FDA and see if we can do the same thing we can do to mice to humans.
It sounds like an incredible medical advancement. So make sure you keep us up to date, and we'll have you back on through that process. But thank you so much for joining us, Dr. Michael Fossel, neurobiologist and author of The Telomerase Revolution.
Thanks, Dr. Fossel.
Yes, thank you.
Thank you all.
Well, thank you for watching and listening to American Medicine Today.